Good evening, everyone. On behalf of the A4M, I'd like to thank you for participating in this webinar. This is a preview of a new course added by the A4M. This course, the nuts and bolts of writing prescriptions for compounded medications, will be held in Delray Beach, Florida, June 26th through the 28th. Presenting the webinar tonight is Dr. Pamela Smith, Director of the Fellowship in Anti-Aging, Regenerative, and Functional Medicine with the A4M. I'd like to ask if there are any questions during this webinar, please submit them via the chat option on your screen, and we'll go over them at the end. Now I will go ahead and turn it over to Dr. Smith to begin the presentation. Dr. Smith?
Good evening, everybody. Tonight we are going to preview a little bit about prescription writing for compounds. In the past, it has been acceptable to, if your compounding pharmacy provided you a prescription, you could check and just sign it, and that would be acceptable for a compounded prescription. In most states now, and in much of the world, it has now changed a new module looking at the idea of prescription writing for compounds. There's going to be some very exciting things that we're going to look at. I'm going to be doing dermatological conditions. We're going to be looking, Daniel Banoff is going to be looking at anti-aging prescriptions. Dr. Sahar Swadan is going to be looking at a lot of things you can imagine that would be fun, from the idea of New Year's Eve to sun in the sun, winter prescriptions, pain control. She's going to be even looking at prescriptions to enhance sexual function. We're going to have a couple of different presenters look at the idea of really what compounding means. We're going to look at wound, we're going to look at scar, we're going to look at the idea of difficult prescriptions. I'm going to be talking a little bit about that along with a couple of the other presenters. We're going to be looking at how you write prescriptions for metformin to be put on transdermally, how you would do thyroid transdermally, just really almost anything you can imagine we're going to cover in this 3 days. So tonight's a little preview on compounding for dermatological conditions. Okay. So we're going to spend the next few minutes talking about hair loss and alopecia. Hair loss affects about 50% of men by the age of 50 and almost 50% of women. Hair loss does cause an emotional stress for many patients. And I'm sure your patients are like mine. They bring in a plastic bag the hair they lost that morning in the shower, so you can actually see how much hair they've lost. There's many different causes of hair loss in general, related to alopecia or not. Certainly hypo or hyperthyroidism can be one of those. Low or high cortisol levels can also be affected as well. Elevated dihydrotestosterone. How do you treat elevated DHT for both men or women? That would be saw palmetto, 240 to 260 milligrams BID. There can be a hereditary component. Progesterone loss in women can cause hair loss. Toxic metals, so you need to do a toxic metal test. Nutritional deficiencies, even gastrointestinal dysfunction can be a cause of hair loss. So, of course, fixing the cause of the problem would be the best thing to do when we look at hair loss or alopecia. So conventional therapies for alopecia and hair loss include many different things, from spironolactone, which is one of the things that can help the conversion of testosterone to dihydrotestosterone. All the other things on here are very conventional therapies which work for some, if not all, patients for hair loss, including hair transplantation, etc. There are metabolic therapies for alopecia and other kinds of hair loss, except for male pattern baldness. First thing we want to do is to stop gluten intake. This is very helpful for many forms of alopecia. Caffeine can be problematic for some people. We are going to look at cimetidine. We're going to look at nutritional supplementation. We're going to look at the 4R program for GI health, melatonin, saw palmetto, and compounded formulas. Okay. Nutritionally, studies have shown that different types of hair loss or alopecia can be stabilized or reversed with nutritional therapies. Androgenic or male pattern baldness, however, has not been shown to be reversible from a nutritional viewpoint. Extensive hair loss due to shedding, telogen effluvium, was seen in one study to occur in patients that were crash dieting after 2 to 5 months on a vigorous weight loss program. So in other words, if the patient just lived on potato chips, or they only ate salad in a day and nothing else, could they have hair loss? Yes. And then, as I mentioned earlier, gluten. For all forms of alopecia or extensive hair loss, it is best to stop all gluten intake. One study of children showed that partial or complete hair regrowth occurred after they went gluten-free. Caffeine. Caffeine inhibits phosphodiesterase, which stimulates cyclic adenosine monophosphate, which counteracts testosterone's effects on the hair follicles. So caffeine lotion and shampoo may increase hair tensile strength and numbers. We're going to teach you how to do that. Cimetidine. H2 blockers are peripheral anti-androgens and block the binding of dihydrotestosterone to androgens. 300 milligrams 5 times a day of cimetidine was one study showed did help with hair loss. By the way, this is not an FDA-approved usage of cimetidine, but it does work in some patients. Remember, if patients do take H2 blockers long-term, however, it decreases the absorption of minerals into the body because the GI tract does have to have acid to absorb calcium, magnesium, boron, zinc, etc. When it comes to nutritional therapies, iron deficiency has been shown to be a common cause of diffuse hair loss. So this is one that you can look at measuring iron. If the patient's iron deficient, replacing it would be very helpful. Another study showed that patients with hair loss that were iron deficient did respond to iron replacement with the hair loss stopping. Iron deficiency does not play a role, though, in androgenic alopecia. So if it's related to hormones, meaning dihydrotestosterone being elevated, then replacing iron is not going to be helpful. When we look at iron deficiency, we know that the hair tends to be brittle, tends to be dry, narrow, or you can have splinting of the hair shaft. This may be due to impaired keratin production, and that may be the actual mechanism why iron deficiency plays a significant role for some patients in hair loss. So again, if the patient has lost hair and they're iron deficient, and it's not an androgenic cause, then supplementing with iron could be very beneficial. Zinc has been shown to help with hair loss. So zinc supplementation can be very helpful. There's many ways that patients can become zinc deficient. It may not even be a poor diet. For some people it could be. But for other people, ACE inhibitors have been shown to cause zinc deficiency. So in fact, that's quite a common cause. Essential fatty acids. There was a case study of patients receiving hyperalimentation that was fat-free. Because they didn't get enough essential fatty acids, the patient developed alopecia and scaly dermatitis. Symptoms were reversed when they were treated with essential fatty acids, in this case EPA, DHA. Biotin. We talk a lot about in some of the modules about biotin helping with hair and nails. It really does help. Studies have shown that biotin deficiency can be a cause of hair loss. When it's replaced, hair growth occurs, and it does take larger doses of biotin. Routinely, we get 200 or 250 micrograms of biotin, but for this purpose, 2 to 5 milligrams would be best. I usually do have that compounded. And the reason I do is that people don't have to take so many pills. So you would just write biotin, for example, 5 milligrams, number 30, 1 QD. That would be great for biotin as a compound. Biotin does regulate mitochondrial carboxylase enzymes in the hair root. So this may be part of the mechanism why biotin is helpful for hair growth. Alopecia may occur due to genetic biotin dependency syndrome. So there are some people that genetically have a hard time with the mechanisms where biotin helps with hair growth. Those people may need to take additional biotin permanently. Biotin deficiency and subsequent possible hair loss can be due to other medications, or can be due to medications such as anticonvulsants. In fact, as you're about to see, anticonvulsants can cause other nutritional deficiencies that can also be related to hair loss. So if the patient's on phenobarbital, they're on Dilantin, they're on Tegretol, these are the kind of medications we're talking about. Also be aware that cigarette smoking can cause biotin deficiency. Other diseases associated with biotin deficiency are the aging process. If people drink alcohol to excess, people who are vigorous exercisers, so they marathon 3 times a week, they pump iron 7 days a week, people with intense athletic competition may become biotin deficient. Patients that have suffered severe burns, patients with bowel resections, patients with partial gastrectomy or other causes where they're achlorhydric, patients that ingest raw egg whites can become biotin deficient. Still looking at nutritional therapies, folic acid deficiency as a possible cause of hair loss, particularly in pregnant women, and also with the use of estrogen, since estrogen supplementation can cause folate deficiency. B6, in an uncontrolled trial, vitamin B6 supplementation was shown to be helpful for women with diffuse alopecia. Another study, uncontrolled one, showed that vitamin B6 supplementation was effective for hair loss in women that took oral contraceptives. Because, again, oral contraceptives, because many of them contain estrogen, can cause B vitamin deficiency, including B6. B12, studies showed that B12 supplementation helped with alopecia in animals. So that may be something we can look at as well. Amino acids. Anecdotally, it's been shown that if you measure amino acids and you find a patient has many deficiencies, you can have this compounded. What you do is you take the amino acid formula that comes back on your test, and then you send that to the compounding pharmacy. They make it milligram for milligram, and that's been shown to help with patients with hair loss when you have those amino acids compounded. And they can be compounded as a powder. People can put it in water and drink it, or it can be compounded as pills. And this has helped prevent and reverse hair loss. Vitamin A. Hair loss can be a manifestation of vitamin A toxicity, so sometimes too much can be a problem as well. Case study of a patient on hemodialysis who was taking only 5,000 international units of vitamin A for 2 years. They developed hypervitaminosis, they had hair loss, and the vitamin A was discontinued. It only took 1 month for the hair loss to resolve. Vitamin D. Studies show that low vitamin D may be a cause of hair loss. And those same anticonvulsants that we talked about earlier, phenobarb, Dilantin, Tegretol, can also cause vitamin D deficiency. So several reasons why someone on anticonvulsants could end up with hair loss. Of course, the 4R program. Have to have a healthy gut to make hydrochloric acid. You also have to have a healthy gut to absorb those minerals, so that we know that hypochlorhydria can lead to impaired protein digestion, decreased absorption of nutrients. If there's not enough good gut flora, then not enough nutrients will be made, particularly biotin, since biotin is made in the gut. And pancreatic enzyme deficiency can also cause malabsorption of essential fatty acids and zinc. And we've just learned that essential fatty acids and zinc are very important for hair. So the 4R program will remove the offending agent, replace, reinoculate, and repair, as we discuss in Module 3 and Module 5, very important for hair and hair regrowth. Melatonin. It's a very interesting hormone that we talk about for sleep. We talk about melatonin in Module 1 being very important for the immune system, but melatonin also has anti-androgenic effects on the hair follicle. 1 milligram of melatonin, topically compounded in alcohol and glycerin, can be applied in the evening, left on all night, and the person gets up in the morning, has been shown to be helpful if it's an androgenic cause of a problem for hair loss. Saw palmetto, we mentioned earlier, inhibits 5-alpha reductase conversion of testosterone to dihydrotestosterone, and studies have shown this one was in males, again 240 to 260 milligrams BID. And then, of course, we can actually compound many different things. This is a compounded formulation that Dr. Swadan and I use all the time for hair growth. It's got coenzyme Q10, EGCG. Now, it's very important with the EGCG that you use a greater than 90% powder. Sometimes I see this compounded with less than 50%. It doesn't work as well. I can tell you that from personal experience. The EGCG needs to be greater than 90% powder, 0.1 gram, plus vitamin D3, 0.2 grams, and that's if it's 100,000 IUs per gram. Put it in an emollient base. Usually 120 cc's is great. Apply it at bedtime, leave it on all night, and we have had great success with this for hair loss. So, great compound to write. You can have chemotherapy-induced hair loss. Patient having chemo, hair loss is a very common side effect, particularly of adriamycin. In one small study, patients on deoxyrubicin, which is adriamycin, they took 1,600 international units of vitamin E. 69% did not develop alopecia. Or if they did develop alopecia, it wasn't severe enough that they needed a hat or a wig. The risk of getting hair loss was less. The patient started on vitamin E 3 days before they got chemo, and it did not hurt the effectiveness of the chemotherapy. In 2 other trials, vitamin E did not help patients that were on combined chemotherapy. So it helped if it was just adriamycin by itself, but it did not help if it was chemo that was adria plus another chemotherapeutic agent. Another study was done, this one on laboratory animals. Supplementation with coenzyme Q10 helped prevent deoxyrubicin-induced hair loss. Of course, this is not surprising, since adriamycin is one of those chemotherapeutic agents that depletes the body of coenzyme Q10. We know we can give Q10 along with adria. Again, does not affect the effectiveness of a chemotherapeutic agent. So the patient would need at least 100 milligrams of pharmaceutical-grade coenzyme Q10. Medical trial that was double-blind, subjects with ovarian cancer who took cisplatin and cyclophosphamide and a multivitamin with or without selenium. They discovered that the patients that took the multivitamin with the selenium, their hair loss was lower in 60 to 90 days. Kind of interesting trial. In a single-blind study, IV glutathione, there's your dosage. With each chemotherapeutic infusion, they had lower rates of hair loss if the patient was getting cisplatin. So another way of looking at this as well. Okay. If you're looking at alopecia areata, totalis, or universalis, we know that autoimmune disease, alopecia is definitely one where the body attacks its own hair follicles. So if we're looking specifically at alopecia, and not just hair loss in general, then glucocorticoids and contact hypersensitization are looked at as conventional therapies. Metabolic therapies, we know that zinc is very helpful. In this study, 15 patients with alopecia areata got 45 milligrams of zinc TID. That's a big dose. Obviously, this would only be in people with normal renal function. They had complete return of hair growth within 6 months. Another study, same researcher, 43% of 42 patients with alopecia areata remained in remission for 1 to 4 years after zinc therapy without further zinc being needed the entire time. Here, over 100 people with alopecia totalis were given 45 milligrams of zinc 3 to 6 times per day for several years. Almost 1/3 had full regrowth of hair. Another 1/3 had partial regrowth after 2 to 3 years. Again, normal renal function. And then again, biotin. Small study of children with alopecia areata were given systemic corticosteroids or the combination of zinc aspartate and biotin. After 1 year, that was also with clobetasol, propionate topically, that was compounded, after 1 year. 1/3 of the patients receiving combination therapy had complete regrowth of hair. None of the people receiving just systemic steroids had complete regrowth. So, interesting one as well. And then vitamin A case report, patient was vitamin A deficient. Remember, too much vitamin A can cause hair loss, but in this case report, the patient was vitamin A deficient. They had alopecia areata. They received vitamin A and their hair regrew. So this gives us some different ideas looking at different kinds of hair loss. Of course, we always want to go after the cause of the problem, but we can compound in many different ways, either biotin by itself. We can look at the formulation of the coenzyme Q10, the EGCG, and the vitamin D, very effective for hair growth, along with some of the other therapies we discussed tonight. So just a bird's eye view here, looking at one of the subjects we're going to discuss in the compounding module. I hope all of you decide to join us, and that is June 26th through 28th in Delray Beach, Florida. It will be at the Marriott there. It is on the water, so it's a beautiful, beautiful piece of property. And again, we're going to look at many different subjects to write compounded prescriptions for. Questions?
We don't have any questions submitted. I would like to thank everyone for attending this webinar, especially thank you to Dr. Smith for your time and for this great presentation. If anyone is interested in registering for this event or to find out more information, please call the A4M office at 888-997-0112 or visit a4m.com. We hope to see everyone June 26th through the 28th for Module 24. Again, thank you for your time, and thank you very much, Dr. Smith.
You're welcome. Have a great night, everyone.